Okay, we're live.
Great. Good afternoon, everyone. Welcome to this meeting of the Health Policy Commission. Welcome, commissioners. This is our first full board meeting that we'll be conducting virtually. From everyone at the HPC, we hope that you and your loved ones are well and healthy during this time. For the members of the public and market stakeholders who are watching this meeting on our live YouTube channel, thank you for your ongoing engagement and interest in the work of the Health Policy Commission. You can find today's slide presentation and accompanying materials that we will review this afternoon available on our website now, or I do believe there is a link in the video description on the YouTube page, which will link to this presentation. Additionally, we encourage you to follow us on social media, on Twitter, at Mass_HPC for all of the latest news from the HPC. We hope to stay connected to you in this new virtual world. Today, we have a full agenda. We plan to continue discussion on the impact of COVID-19 on the Massachusetts healthcare system, financing, delivery, and payment models with a presentation from David Auerbach with the latest data and research. As part of this discussion, we will publicly present for the first time a few preliminary results from a very recent survey of Massachusetts physician practices on the impact of COVID-19. Following this presentation, we hope to continue a board discussion on the HPC's priorities for the rest of the year in light of the pandemic and its historic disruption to our healthcare system. On behalf of the HPC staff, we recognize that our work will need to rapidly adapt and evolve to meet this moment of significant challenge and opportunity in health policy. And we are energized and ready to continue the work of advancing better care, better health at a lower cost in the context of a new reality, of course, with your guidance and leadership. And of course, with the ongoing collaboration with our stakeholder and interagency partners. So we're looking forward to a really robust conversation today and in the upcoming weeks about the HPC's role moving forward. Today, there will also be a vote on establishing the healthcare cost growth benchmark for 2021 as required by Chapter 224. And finally, today, we will have a vote to approve the final awardees of the Moving Massachusetts Upstream Investment Program, which was developed in close partnership with the Department of Public Health and other state agencies. 4 incredible proposals emerged from the selection process, which together represent $2.5 million in funding to address social determinants of health relating to economic stability and food insecurity in several communities across the Commonwealth. The vote today will be a culmination of a highly competitive review and selection process, which included reviewing 22 proposals with funding requests that exceeded $14 million. Due to our resource constraints, we were only able to fund 4 awards for a total of 2.5. But now more than ever, innovative investments by the state into our communities is essential to improving population health and reducing health inequities and healthcare spending. The COVID-19 pandemic has magnified such inequities as communities of color in particular have been disproportionately affected by both the health and economic effects of the pandemic. So we're thrilled to be able to recommend a set of very innovative and thoughtful proposals, all of which were developed and designed by the healthcare applicants with their own community partners and the voice of their community at the table during the development phase. My only wish is that we had more resources to fund even more awards. We had a lot of really good proposals, but more on that later. So with a full agenda ahead of us, Stuart, I'm going to turn it over to you for any opening remarks.
Thank you, David, and welcome everyone to our first virtual board meeting. As David pointed out, once we officially approve the minutes, we're going to have an extended period of discussion about really our research and policy agenda for at least the coming year. We're going to ground it as much as we can in data, which, as David pointed out, David Auerbach will take us through. But I also encourage my fellow commissioners to engage in a broad-based discussion about how you see the work of the commission have, dovetailing with pressure or aspects of the health system to change. Now, just because there's no question we're in a very unique and not very pleasant environment, and there are important trends that are emerging. It's not at all clear that all of those trends will continue once the virus has been slain. But some will continue and some will continue with our help. So feel free to open up the discussion. I want to say in the beginning that we do function within a fairly broad charter, but it is not totally unconstrained. So there may be some aspects that some of you would like to see us pursue that we may need to sort of put on a back burner, because really it takes us way beyond where our charter allows us to go. But in the broad-based area of being concerned with the cost of healthcare in the Commonwealth, access to care by different population groups, the quality of care, we can engage in a fairly broad-based discussion. So, Colleen, you can help me when somebody wants to speak. I can't see everybody's face, so you will have a sense. Just let me know whose hand is up.
Will do.
Okay, and you can indicate that you want to speak. There's a little doozy that, Colleen, you can explain how they indicate that they want to talk.
Sure, there's a little participant button on the chat function, and you just raise your hand. Also, if you just raise your hand, I can see you too, so I can unmute you. Otherwise, we're going to keep you guys on mute for the majority of the meeting.
That's right. Colleen's my right and left hand here. And of course, David, feel free to jump in at any time. So let us first approve the minutes for the February 5th board meeting. So is there a motion to approve, and then we'll discuss it? Okay.
A motion from Ron and a second from David Cutler.
Very good. Thank you very much.
Sure.
Are there any corrections, additions? Anybody wants to bring up?
Sorry, Stuart, but we do have to take a roll call vote.
I know that. Yeah. But first I want to get any additions and corrections. Do I see any? Colleen, none?
None.
Okay. Now, as Colleen just mentioned, because we're in a virtual, we need to all take a roll call. So Colleen, why don't you just call them off?
Okay, great. Ron?
Unmute anybody.
Sorry, my unmute powers are not working, so I need everyone's help. I'm going to call on Commissioner Cohen.
Aye.
Commissioner Blakeney,
Aye.
Commissioner Cutler,
Aye.
Commissioner Roeder,
Aye.
Commissioner Foley,
Aye.
Commissioner Lord,
Aye.
Commissioner Kreider,
Yep.
Commissioner Peters,
Aye.
Commissioner Master-Giovanni. He says aye. Lois, does that count? Yes. Commissioner Altman, Chairman Altman,
Aye.
Commissioner Berwick.
Aye.
Did I miss anyone? Okay, unanimous.
Okay. All right, so I'm going to turn this back to David Seltz, who will make any introductory remarks and then turn it over to David Arbach. David?
Great, thank you, Stuart. So for the next part of the presentation, we wanted to update some of the research and data that we presented last to you at the May committee meetings, where we now have another month of data, a lot of data through April. And April is where we see the most dramatic impact of COVID-19 on healthcare spending and utilization. So some of the figures that we showed you even a month ago have changed quite dramatically. And I guess I would say, as a note of caution and disclaimer, these data trends are changing on a daily basis and in a very rapid way. So the data we'll present today is typically through mid-May, although we know that even beyond that point, there continues to be many interesting trends. And so we plan to continue to update you, the board, as well as keep a compendium of some of this research on our website so that the public will be able to see all of the latest that we've been able to mine from a wide range of national experts and local experts, as indicated in the notes. So we'll have a few additional data slides. As I mentioned, we're going to have some new survey results from Massachusetts-based physician practices, and then a lot of time for discussion. Please, of course, raise your hand along the way if you have questions. That is absolutely welcome. And David Auerbach, I will ask you to pause and after certain section breaks to see if there's any interest in conversation or questions. So with that, David, I will turn it over to you.
Sounds good. Okay. Thank you, David, and welcome everyone. We do have a number of slides to go through, and that introduction was helpful, and that's a good preview of what we're going to see today. Let's go to the next slide. Okay. So to start out, this slide is summarizing our best estimate as to what we think the peak of reduction of care was. And that's represented by a number of data sources combined here, which are showing roughly the status of things in April 2020, where almost the whole country was under lockdown, relative to April 2019. So a year ago, full month effect. And in cases where we had regional data representing the Northeast, I'm using that, and that's most of this slide. And so again, since our update a month ago, some of these numbers have changed a bit. This is about where it looks, with ED visits surprisingly down by about 50%. Inpatient discharges about a third, and that's a net effect of increases from COVID and decreases in other areas. So about a third down, and one of the sources did find a significant difference, with a larger reduction among the smaller hospitals and a slightly smaller reduction among the larger hospitals. Outpatient revenue was affected more, on the order of 50% down, and operating room minutes down around 80%. So that's in the hospital. Physician office visits and physician services, similar to what we saw before, down around 2/3. And the next slide will show a little more detail there. Prescription drugs, the least affected, but there still is some decrease, mainly based on fewer office visits, which tend to initiate new prescription drugs. Okay, so let's go to the next one. This trend is showing a more granular week-by-week view, and this is physician office visits. And it's also divided up into the regions of the country, which is helpful. So here you see taking the baseline as the week ending March 1st. That's what we're calling zero in this slide. And this is put together by a number of researchers with the Commonwealth Fund, and David Cutler is included in that group. And here you see that the very large drop with the bottom of that trough being around early April, and the New England line, New England and Mid-Atlantic is on the bottom, so the greatest effect there, bottoming out at around minus 70% office visits. And then interestingly, you see a pretty significant pickup here ending the week of May 10th. That decrease went from about 70% down to about 45% down. So that is significant. And I'm sure that by today, a month after this slide ended, there has been more resumption of care. Okay. This slide is showing a deeper dive of office visits here by specialty, by the type of visit. And there's some interesting variation here to show. If you start on the left, for example, you can see that psychiatry was the least affected among the specialties. And that's mainly because you see the big chunk of green there. The green represents telehealth visits. The blue are in-person visits. And so even though the blue psychiatry visits are down 30% of the baseline, you can see there were more telehealth visits in that area than in-person visits. And that really prevented a deep drop in the area of psychiatry. Then you can look, for example, around the middle, FP, IM, GP, that's your primary care visits, down around 50% of baseline of normal with a fair contribution of telehealth. And then on the right side, for example, orthopedics, emergency medicine, very little contribution of telehealth. And those were down to just the in-person visits of less than half. This is from a different data source called IQVIA, and this is data for the week ending May 1st compared to a January, February baseline.
David, a quick question.
Yep.
Do you know why they excluded internal medicine and family practice?
I don't think, I think that's all combined in that FPIMGP, right? In the middle.
Oh, okay, I missed it. Okay,
Yep.
Got it.
Yep. Okay. Okay, so this slide from the
David,
same. Yeah.
go back to that slide just to understand it. So if you look at the blue, the dark blue, that shows what? So is it 30% of the baseline?
Exactly.
But then the green, which is the telemedicine side.
Yep.
What would that be?
So when you add the blue and the green, then you're seeing the percent of baseline in total visits to that specialty. So psychiatry, about 70% of normal is the total number of visits in that specialty. But the green is making up, 40% of that.
Right,
So,
but the point I want to raise is that the green is not a percentage of the baseline of just telemedicine, because the baseline may have been close to zero.
that's right.
A year ago or whatever. So
Yeah.
the baseline, the telemedicine part, you just add to the in-person to
Yes.
get total. So they're not strictly the same, but they add up to the total, right?
That's right. They're counting.
All right, so be careful. Yeah,
Yep.
when we interpret a slide like this, but the the total, which is the combination, say for psychiatry, is that it's say 75% of the baseline, of which a major section is the telemedicine.
Mhm.
Okay,
Mhm.
but I
Right.
want to make sure that everyone understands that they're not strictly the same, the blue and the green. Okay.
Yeah.
Thank you.
Okay.
So I'm still a little daffy here. Where is the baseline is January, February, right?
David?
Yes. Oh, yeah. Was that a question? Yes.
Yes.
That's correct.
Okay, so we changed the telemedicine rules in Massachusetts in the second week of April. What was it? Maybe it was the first week, but it wasn't. I guess what I'm suggesting is I'm hearing a much greater use of telehealth in practices that I have some relationship to. One organization of 150 primes, 80% of their activity is virtual now, and so I think we have to put a little bit of a jaundiced eye on this until we have all of May, let's say, and then May versus June will be really interesting, or May versus August, or no, not summertime. May versus September will be really interesting because we'll know whether the bloom is off the telemedicine rose from the standpoint of either the doctors or the patients. But I think these undercount significantly.
Okay. The next slide, I think, will add more to this discussion. So that's a good point. We might see more. Let's go to the next slide. It's going to be helpful.
David, just really quickly though, this is national data, correct?
This is national data, so there could also be differences in Massachusetts. Yep.
Yeah, as we're about to show, the uptake in telehealth has been much greater in this region and in this area than nationally. So Dr. Kreider, I think your notes of caution here are well taken. And I would also add, again, more anecdotally, I have heard in conversations with one of the major commercial plans here that the increase in telehealth has continued through into early June and does not seem to be diminishing in this state. And so even looking at data through mid-May may not capture the full impact of how telemedicine has really taken off in this state.
Okay, so great. So this slide, and I'm glad we had that discussion about what these bars mean, because it's a little confusing. There's different ways to look at this. This is from the same data source, but now we see a time trend going from March through mid-May. And on the left, you're looking at total visits by type, by modality. With the green, our in-person office visits, and mirroring what we saw before, we see that dip in early April going to around 70, a drop of about 70%, that's the green line. And then by mid-May, it has picked up substantially. The yellow is facility-based visits, also a significant drop. And what you're seeing in the blue is telehealth visits. And in the depiction on the left, this is growth from its own baseline. And the growth is so massive in a percentage-wise that they have to show a whole different scale on the right. So you're talking, 3,500% increases. The interesting point here is that even as those green office visits have come back in May, the telehealth visits have not really dropped in volume. They shot way up by late April, and they've held fairly steady into May. So that's kind of the point that David was making, and they might still be increasing. And the depiction on the right is more what we were seeing in the previous slide, where they're just counting all visits as equally as one visit and showing the mix of each type. Again, the dark blue is the telehealth, and you can see there as well that as a proportion of all visits, it's fairly high, not 80%, but again, that's probably, there could be regional differences and differences by specialty, but you see that the dark blue segments are not really shrinking even as the greens grow over time.
Yeah, David, let me just emphasize what you just said so we don't lose it. There are a number of people who think of telemedicine as a substitute completely for office-based or institutional-based services. And some people point out that they're clearly better, they're less expensive, they're going to help lower the cost of healthcare. However, to the extent that we wind up with an add-on as opposed to a substitution, which is what the last set of numbers suggest, and I'm not saying it'll continue, you could wind up where telemedicine is not a complete substitute, but becomes partially an add-on. And it's possible that total spending as a result of increased telemedicine will go up and not down. And we want to talk about that, but don't lose sight of that. It may turn out to be as important an issue as any that we talk about.
Okay. Great. Okay, and we have.
Is that right, David? I say that now.
Yeah, I mean, there's clearly some substitution and there is clearly going to be some additional use, and we don't know yet the mix of that and how that plays out.
And I would just add to that, Stuart, to add another complication. Some of those telehealth visits may be meeting a need that was not being met before, particularly in mental health, where we have seen a pretty dramatic increase in use of telehealth for mental health. And we know that there was an extreme unmet need for those types of services prior to COVID. And initial reports indicate very high satisfaction by both providers and patients with that type of modality. So there could be complicating factors here that we also want to unpack and understand.
But to be fair, the psychiatric telemedicine started prior to COVID and had been picking up substantially. What I was referring to is someone that has a perceived issue that they may wait a little while before they actually visit their doctor in the past. But now it's so much easier to get a televisit that you have a televisit, which then says the doctor said, well, I do need to see you. So in fact, what you wind up with is a televisit and an in-person visit, and the total increase is positive and not negative. And that's, because a lot of people, well, I'm not saying a lot, I don't want to overemphasize it. Some, if not saying, well, telemedicine is wonderful, it's going to substitute, and we're going to lower spending. I just color me a little bit of a skeptic. But let's go on.
Okay. Great. And we have finally some more detail on telehealth, in fact, from Fair Health. Now, this data is only through March, but it is very valuable because they break this down into the types of visits at the claim line. And what we see in this slide is that same increase here in a different way. This slide is representing the northeastern US. And as a percentage of all claims, we see in the right segment of this graph, the upper right, the telehealth visits were about 0.07% of all claims in March 2019. And that rises to 11% of all claims in the Northeast. And when you look at what are people using telehealth for, you do see that both in the bottom left there in March of last year, as well as March of this year, mental health conditions are the plurality of more than a third of all visits. So that has stayed the same, interestingly. And then on the bottom right, you see that in fact, there's even a larger jump in urban areas versus rural areas, which is interesting, where you might think the rural areas would benefit even more from being able to use telehealth, although there could be access and other issues that are keeping that a little bit lower. But again, this rise is larger than you saw in the rest of the country in March, which went up to about 7.5% of all claims.
Okay. David, again, I feel like it's really critically important to point out this is March 2020 data, and it is almost irrelevant to COVID because the CMS reimbursement codes did not change until mid-April, as I recall. So I just don't think this. I mean, it's the same March 19 over March 20, but it's going to be different when we look at this. Look at May and June. And one last point on Stuart's concern about whether it is additive to cost. Even if you add visits, you're not adding to cost. Depending upon the reimbursement formula, the cost is so much lower because the support staff are not necessary, because the space is not necessary. So the overhead, both in terms of humans and bricks and mortar, reduces the cost of delivering a telemedicine consultation. And so it's really a reimbursement issue for the payers to figure out contractually. Cost should go down by a lot.
Well, let me,
David,
let's just, let's be careful. It may be, so two things you've pointed out, rightly so. So there is the structural costs underlying the visit. Now, first of all, once if that bricks and mortar are still there, it's going to take a long time for it to be decapitalized, and you don't need it. So for a significant amount, you're just going to have those costs being amortized over a smaller number potentially of visits without reducing the costs. And B, you don't have immediate reductions in the staffing as a result of that. You may, so first of all, there's the underlying costs. And then as you pointed out, there's reimbursement. They're not the same. The reason why I maintain a fair amount of skepticism is I've lived through two very fundamental changes in the practice of medicine. One was, if you go back far enough, the only kind of medical care we covered was inpatient care. And the argument was, gee, we got to cover outpatient care because it's going to be a complete substitute and we're going to save all this money. Well, it did reduce the amount of inpatient care relative to outpatient, but the net result in total spending was up, both in terms of the pricing and in terms of how we allocated costs. The second thing was home health, where if all the people were arguing home health is going to save us a ton of money. The evidence is very mixed. We wound up using a lot more home health. We didn't cut back nearly as much. So it may turn out, Chris, that you're right, but until we see the strong trends over a long period of time, as I said, I just color me a skeptic that we may wind up, but we'll see. Don, you wanted to jump in.
yeah, two quick questions. David, did you stumble on any information about non-billed telehealth? One imagines that there might be a lot of it going on that isn't being reflected in billing. And second, what impressions did you have about quality? I mean, do patients really like it? Is this a real enhancement in care from the viewpoint of the public? Any knowledge of that?
Mm-hmm. Great, those are good questions. All that I know there is anecdotal, but for example, on the first question, I've heard a number of folks say that they are doing a very large amount of email with patients, of quick calls, of just the whole spectrum of virtual and asynchronous ways to contact patients. And most of that isn't going to show up in any billing and isn't reimbursed, of course. And that's kind of getting to what I hope to get to a few slides from now, is how do we pay for all this, and how should we pay for all this? And I think that's an important discussion. And in terms of quality, I don't think we know anything new yet about this. There have been studies in the past, but there are folks looking to to field patient surveys about telehealth, and we're talking with someone about that possibility. I don't know if it's going to work out, but there's a lot to learn. There's a lot to learn about that, and it's, you know, we're talking about telehealth in these last few slides as if it was a homogeneous thing, like a visit, but you're right to point out that there's really there's a lot of different kinds of telehealth. There's a lot of lengths of visits, and there's a lot of you know, uncertainty and confusion about what to call things and how to pay for it. And that's an ongoing discussion.
Thank you, David.
Okay, so let's shift to, so that's the end of the portion of the industry data in this discussion. What we have here is another look at what's been going on over the last few months, and this is employment. So this is data from February through May of 2020. It's national data of the number of employees, of workers in the different sectors of the healthcare economy. And some of us have seen some press releases on this, and it's pretty striking and totally unprecedented. So what we're showing here is calling February 2020 the baseline, total employment in these healthcare sectors. And you can see by March, there's not much change, but following the black line, which is the overall, total healthcare employment nationally is down about 6% from what it was in February. And there are interesting differences by sector. You can see, for example, towards the bottom there, offices of physicians, outpatient care centers, and this is all employees, not just doctors and nurses. Those dropped more significantly in April, down 10%, 12%. And by May 2020, they have come back to some extent. You can see hospitals and nursing homes somewhat differently. There was a shallower dip, maybe 2, 3, 4% drop, and they continue to drop into May. So somewhat different patterns there by sector. It looks like the hospital employment is you know, there's been more COVID care there. It's been a bit stickier to respond. So big differences. If I showed you dentists, which are not on this curve, the drop is so large and then it comes back so much that it dwarfs everything else on this scale. Now in the lower left box, we do have some data from Massachusetts. It's only going February through April, but it presents an interesting contrast. And this data is a little bit noisier, but you know, in comparison, we had a much larger drop of employment in physician offices, 30% compared to the 12% shown here nationally, and a larger drop in outpatient care centers and nursing home and home health. And interestingly, almost no net change in hospital employment. So that physician drop was about 3 times as large. And that's a good tie into the next section where we'll be going into that survey of physician practices that David Seltz mentioned.
Tim, did you want to jump in?
Yeah, please, just one question. In these numbers, how do you account for furloughed workers versus folks that actually got laid off from their jobs?
That's a great question. I guess to some extent it depends on how they respond to the survey, but for the most part, I think those are going to be counted as a loss of employment in these surveys. But it's not entirely one for one with a permanent job loss. That's a good point. And you're seeing a lot of that come back in May.
David,
a lot of furloughed employees during this time period and slowly coming back versus actual layoffs. So there's a little bit of a differentiation, not much. Just wanted to get a sense of that. Thanks.
Yeah, thank you.
David, if I could ask, do you know why the BLS does not include employment at insurance companies as part of this? I mean, it's certainly a direct participant in healthcare employment. And it would be especially interesting to know what, if any, actions that the payers took at a time when everything was dropping off and the volume of activity was so much less. Shouldn't the BLS collect that, or do they collect it in a different way, in a different service sector? You know, is it finance and administration or something else?
That's a good question. I have not specifically looked for that, but I'm I'm guessing that they don't have that category. It might be just too small among the categories that they capture, but that's something that I will look at and get back to you if I can find anything.
And is it
David,
a number
David,
that we could obtain in Massachusetts simply by calling them up? I mean, we only have to get 4 or 5 phone calls and say, what are your numbers? Because we'd like to plot them against what's happening on the delivery side.
David and Chris, they do keep those numbers, but it's a separate industry. So this is the medical care industry, and that's the insurance industry. So they would actually have them. They'll have monthly data on the number of people working. They group life and health insurers together because they're often the same firms. Okay. So they will have that. It's just a different industry.
Yeah. So yeah, got it. David, can you overlay that? And we'll have to discount life for health with health, but is any reason not to be able to do an overlay?
Yeah, I'll see if I can find that. Right. If it's life and health grouped, I'd want to know something about the proportion of each, but I bet we wouldn't find so much of an impact. But yeah, I'll look into that for sure. Thanks. Okay. So let's move to this physician survey. So this is fantastic data, and a really big thank you to the folks who are willing to share this. It's preliminary. It hasn't been published, and this is a large collaborative effort of a number of folks, and including Zuri Song, who some of you know, who's willing to share some of this early snapshot of some of the data they're collecting. What they did was from around May 20th to right up until yesterday, they surveyed a large number of Massachusetts physician practices of different types, about 400 represented here in the couple of slides that I will show. These results are weighted by the practice size, by the number of physicians there. And again, a caution, it's not necessarily a representative sample of the whole state. It was done very quickly, but it should be a fairly good representation of what we might see if we had such a sample. And what they did was they asked these practices a number of questions about how is the pandemic period affecting your practice? What are some responses that you've been taking to try to cope? And a lot of that is what's shown here. So this was the question, what have you been doing in response, or what do you expect that you might have to do in response to the massive reduction in care that we showed in the earlier slides? And you can see these results are arrayed by type of care. Primary care is on the left, behavioral health, and so on. And practices were able to check multiple responses. So these are percentages, but they add up to more than 100, of course. So you see in the primary care up there on the left, more than half said things like, we have been furloughing or laying off employees, we've been cutting salaries, we've been cutting services or operating expenses. And that's true for most practices, a little bit less for behavioral health practices. Interestingly, what I circled there was something that we've been thinking about is, are these practices going to find themselves forced to consolidate, or would they see that as an option? And about 20%, you can see in the bluish there, said that they expect that they would consolidate with other practices, and 18 said that they would consolidate with hospitals or health systems. And this is what they think that they would do. Okay, but those are interesting responses, and you don't see that as much in the behavioral health or in some of the other types of practices. Well, it's fairly present in the other physician practices as well. Okay.
So David,
Yeah.
When you talk about selling the practice, which is that brownish color, which is the largest in the primary care, question is whether that is a subcategory of the consolidation, because often they're going to wind up selling it to a hospital or a for-profit consolidation group that's consolidating physician practices. So,
yeah,
that's an important number, and as important as the consolidation.
Yes.
Who they selling it to? Don, you want to jump in?
Yeah. The other striking number is the percentage saying close the practice. That would be, that's dramatic and way above what I thought. we'd be seeing. Do you think that's real? That's real? That we could actually see these closures?
We might. As time continues to move on and they get more responses, well, we should have an update to this. But you know, that 30% drop in physician office employment in Massachusetts, that was pretty striking. But again, it's also true that when people say what they think might happen, it's, you know, we know from just survey experience overall that it's not always exactly true what they think will happen. So
David, you've done such
so
a great job. I'm sorry to add complexity, but do we have any geographic look at this where we see whether underserved areas of the state or particular geographies or types of areas are especially hit?
I think they do. And we could ask for that. Yep. They also have detail by whether it's an independent practice or by whether it's hospital affiliated and so on. And there are some differences there. I just saw some of that data last night, but don't have that here yet. But there's definitely a lot of richness in this survey that we could have in the future. Okay, and the next one is also important. When they asked these practices about how favorable they felt different modes of reimbursement were, you can see the responses by type of practice. Pure fee-for-service is that dark blue. And then they asked them about a number of different alternatives to that. And this is a qualitative scale, as you know, how favorable, and I think it runs from 0 to 10 roughly. So just look at that as, you know, as relativities. Partial fee-for-service with a bundled payments is the red. Partial fee-for-service with a prospective per member per month payment is the green. That's sort of what we call partial capitation often. And then a pure prospective full capitation is that orange. And interestingly, what I circled here was that among the primary care practices, that partial capitation, partial fee-for-service with the PMPM was the most favorable of all the options. Not as much true among the other types of practices. And I kind of like to see these data against how they are actually paid today, and they probably have that too. But this is an interesting point, and this is a lot of what this coalition is thinking about. Is, you know, how would you work out these payment structures? Okay. So in the last section here, just a couple more slides, I'd like to talk about some of how we're thinking about this data in terms of overall spending trends and in terms of Massachusetts providers and impacts. So what we have here is a couple of studies that have estimated what they think the impact will be for all of 2020. And this was helpful to us in thinking about, again, how do we think different provider types in Massachusetts might be affected by this? And we embarked on a modeling exercise that I'll talk about. So first we needed to come up with an estimate of the total impact on spending for the year 2020. And this is also helpful as we think about the benchmark. These studies, there's of course a lot of uncertainty and there's a wide range, but given what we know so far about the pattern of care coming back and resuming, they've projected on the order of a 10 to 12% reduction in non-COVID care for the full course of 2020. So that's about a 10% drop compared to what we saw in 2019 in terms of total spending. And that's the drop in non-COVID care. They've netted that out against the increase in COVID-related spending on the right, which is much smaller. That's in the order of maybe 1-2% as things look like they're going now. You know, who knows if there'll be a large wave in the fall, but in any case, that is smaller. And so you end up with a mid-range estimate of something like a 10% reduction in spending for the year. So we created a glide path for what that might look like as care returns. And what we then did was we took the different effects by category of care. The inpatient that we saw earlier, the outpatient, the labs, different magnitudes. And we combined that with what we know about patterns of spending for different types of hospitals, for different types of provider organizations. And we then played that out as to what that might look like for all of 2020. And I'm only showing one slide on that, which is the next slide, but just to give you a sense of some of the qualitative differences that we saw when we did that exercise. A couple of things. We were most interested in who was affected more and who was affected less, rather than the overall magnitude, which is again incredibly uncertain. And among the groups that were affected a little bit more than others were the community hospitals or the community hospital systems and the physician-led orgs and the community health centers. And the intuition there is on the community hospital point, more of their revenue is from outpatient care. It's something on the order of a 1/3, 2/3 mix, 1/3 inpatient, 2/3 outpatient, whereas the AMCs are a little closer to 50-50. And the outpatient care is more affected by everything that's going on. And so then you end up with the community hospital systems being a little more affected in terms of a reduction in revenue, a reduction in spend. And that's on top of the weaker financial position they were in to begin with. And I'm showing that by one statistic. There's a number of things you could look at, but if you look at how many days of cash on hand does the system have, and we graph that below, the community hospital anchored systems had less. They're on the left, especially the ones with a high public payer proportion that compared to the AMCs or specialty hospitals, for example.
David?
So, yeah.
David, can you go back to the estimates from like Milliman and are they
Sure.
talking about the whole year or are they talking about up to now?
The whole year. They've
So
spread
the question becomes, if they break so I wouldn't, and I'm sure they didn't either, project from the lowest point. So if you looked at the reduction, say through April,
Mhm.
it's going to be much greater than what is going to be for the whole year because those lines are coming back up.
That's right.
So they've done some estimates of how much further these lines are going to come up,
Yep,
right?
that's right. That's right.
So these are net through the end of the year, not
Net
just for the period that we have. Okay.
That's right. But
I
both of these projections assume that by December of 2020 that care is maybe 5-10% down from what it normally would be. So they're just projecting out this glide path, as you saw on some of the earlier slides, and saying, what if the return looks like this? And that's why they have such a large range, of course. That's the uncertainty.
Lauren, you have some comment?
Sure. Just actually a question. Just to confirm that the spending is both public and commercial payers, or is it just commercial?
Oh, that's a good question. The Milliman exercise was all payers, and they broke that out. And as I'm saying there, that's right. They found that commercial spending was more affected. Medicaid was least affected. That is partly because most of the COVID patients are Medicare at this point. So there's a lot of the positive revenue is coming from Medicare to net off of these losses. So yes, everybody's talking about all care there. Okay. And so that's what we saw with the community hospitals relative to some of the other hospitals. And then a similar story with the physician-led organizations and CHCs, in that they don't have inpatient revenue, and whereas the inpatient revenue is the least affected of the different sectors and categories, or maternity is almost not affected at all. So these types of organizations were facing a larger reduction overall over the course of the year. So we will continue to do that as more data comes in and have more detail at a later date. Okay, so I'm ending there. Let's turn it back to David Seltz.
Great. Thank you, David, for walking through that data and the update. And as we said at the beginning, understanding the data is shifting rapidly, and we are doing our best to try to stay on the cutting edge of whatever we can learn as more information comes in. Wanting to shift the conversation now to open it up for a board conversation around how the HPC should adapt and evolve its policy priorities and work streams for 2020. in light of some of these incredibly important questions and challenges and opportunities in our healthcare system in Massachusetts. I think one of the things that is so unique about the Health Policy Commission and our staff is that we have been able to build expertise that is nimble and flexible and can be rapidly adapted to the questions of the moment. And that's something that we've built up over a number of years, recognizing the speed of which change happens in this particular market. That speed has accelerated to warp speed. And so want to engage in a conversation with all of you today about how we can adjust and adapt, should adjust and adapt our research agenda, our policy agenda, to best be able to contribute positively to the Commonwealth, the healthcare system, and working with our other state agency partners in this reopen recovery phase of healthcare in Massachusetts. I'm including a slide here. This is very similar to a slide that was shown at the committee meetings in May. I have not edited it much, and really wanted to reflect it here again. I won't talk through all of this, but to put out some of those areas where we may be well poised to contribute and to lend information, research, and policy recommendations in areas that are aligned with our past work and our statutory mandate and responsibilities. So with that, Stuart, Lauren,
Yeah.
I'll let you.
So let me just put on the table without several other areas that we need to potentially look at either by ourselves or in conjunction with other state agencies, which were not reflected in the statistics that David Auerbach showed us. One, and in no particular order, you know, our health system in many ways did incredible things. And we should give a big shout out to the amount of work that went on by our physicians, nurses, health personnel. But it also showed some weaknesses given the way we're structured, and some strengths compared to, say, other countries or even other parts of the US. And I'm just going to throw them out. One is that in the past, and I haven't seen it in several years, one of the concerns that some of us had why our healthcare system was so expensive is that we had a larger percentage of our beds as ICU beds, which are much more expensive to keep online. How ironic, of course, is ICU beds became very important in taking care of the sickest COVID patients. So we need to put on the shelf this issue about ICU beds. Is there a right amount? Should we have in reserves? Second, obviously, is the whole area of testing. Who's responsible for it? Should we have it done by the state? The state is passing it on to the federal government. Third is the whole inventory situation. Hospitals, under the pressure by a lot of the business school types, have been moving much more to very limited internal supplies and inventory, and relying much more on very quick turnaround in terms of suppliers, which of course turned into be a big problem in some parts of the country as the need to generate up moved too quickly. And second, there's also a big issue about how much we can rely on supplies from other countries. And then, as was pointed out here, the whole workforce capacity. So and there may be others, I'm just doing it, just the idea that as we think about both what we've learned or where we need to go, Obviously, there's going to be a lot of differences, but I throw those 4 areas and maybe I'd add a 5th, which is that last slide. If we wind up with closing more rural and smaller community hospitals, what is the impact on A, access, and B, consolidation, which could lead to high, as we move more patients into our higher cost academic medical centers, which is an area we've been concerned about. So with that said, Don, you want to jump in?
Thanks, Stuart. So in just a process check. So right now, David and Stuart, we're collecting ideas right now. So is that right? Because I as well, but I don't want to overwhelm it. Is that right?
I bet that is fair, Don. We are hoping to have the board give us some guidance and leadership. I'm not. This is not a proposal as much as a launching pad for conversation.
So here's a list to supplement what Stuart said. In no particular order, I think a Commonwealth strategy for testing, and then for once treatment and vaccines are available, we should not get behind the game on this. So when and if a vaccine arrives, when we have antivirals, what is our policy going to be, and how are we going to approach it in terms of access and cost of these things? And Stuart also correctly flagged the testing strategy. Second is pricing. We've already seen it in the telemedicine world. The CMS telemedicine regulation simply pays for a telemedicine visit the way it would have paid for a face-to-face. I think that has to be scrutinized very carefully, and I think the commission may have a contribution to make in terms of a rational telemedicine price to guide the public sector, but also for private, to guide the private sector, but also for public sector approach. Similarly, when vaccines and antivirals are available, there will be a pricing problem. Some of these will be monopoly products, and I could imagine some real serious questions arise about pricing at that level. The next is preparedness itself. We, like the rest of the country, we're caught on our heels, and the question is, and this probably is longer term, is what is preparedness at the state level, and how does that factor into cost? Because when we're asking facilities to be prepared, they're going to have to change their approaches to inventory, data systems, and so on. The last is my most important point by far, which is racism. We see it in the data in the state, the racial differences with the George Floyd murder and the mobilization now in the streets. I just do not think any responsible public agency can or should fail to confront that. And so that's a big topic. And I think I would be proud of the commission if we would take that on frontally as its own topic. It's not on the policy and priority work stream list in any explicit form. And I think now it has to be.
Thank you, Don, for mentioning that. David Cutler.
Thanks. Let me just echo some of the earlier comments, but add a couple of my own. I think the issue of what happens to payment policy is really important. And if we just go back the way we were, then the system will go back the way it was. And want the system to be different, we have to think about that issue. And so I'm glad to see it on the list. 2 other things I think that are not on the list. I know one we're coming to, which is the benchmark. And there are sort of rumblings that folks are saying, well, to heck with the benchmark, we need higher prices now because of COVID stuff. And I think that's a real mistake. I think there is going to be an issue for the private sector, which is that people are going to lose their employer provided insurance and they're going to go onto Medicaid or onto exchange policies, Commonwealth connector policies, and that's going to pay them less. But rather than saying, well, we're going to make it up by charging more to those who still have private insurance, I think we've got to think of other ways to help folks reduce the costs of care rather than to just shift the costs of care onto the that dwindling pool of people who pay higher prices. So I think we have to be quite vigilant about the benchmark in all this, and not just say, well, it's COVID related, so therefore you can do what you want. And the final thing I'll say is that what's been exposed a lot as being I don't know, significantly less good than we hoped was care in nursing facilities and assisted living and long-term care and so on. And, in Massachusetts, about 60% of the COVID deaths have been in nursing homes. And I think we need to really look at that. The pay in nursing homes is extremely low, so the workers are not long-term workers. They're in and out. They're people who are living in areas where there's a lot of COVID. They don't have as many safety precautions. They don't have as much PPE and so on. And so it's not us totally, but we can engage with the state in helping to think about what we should do about the nursing home community, because it's really just been this, for everything that's gone really well in the hospital industry, things have gone just extraordinarily poorly in the nursing home industry. And that's a real problem here.
Absolutely. Lauren?
Sure. I just wanted to, I know that this slide is sort of forward thinking in terms of what is, what are the priorities and work streams of HPC look like on a going forward basis. But I do want to just, David failed to mention that all of the work that David and the HPC staff have contributed to date in the Commonwealth's response, I mean, it's just really been tremendous. The versatility, the word that David used earlier, is really spot on. We've been able to leverage the expertise and really the sort of the fluency with the healthcare system that the team has on a myriad of issues. And so we are incredibly grateful for that. And with respect to many of the items that other folks have raised in terms of to put on the agenda, including testing, health equity issues, these are all, many of these issues are being certainly covered and addressed through the command center. And I would sort of invite and welcome, think about ways that we can leverage, again, HPC's expertise to help partner and address many of those initiatives and efforts.
Well, thank you, Lauren. And I was going to bring that up. Obviously, we are very fortunate living in Massachusetts that we have a lot of very talented people and a lot of talented organizations other than the Health Policy Commission. And, as we've done in the past and we'll do more, we will work very closely with the other organizations. And as we've done in the past, we will act in some cases as a data analysis where the main responsibility will be in, say, the Department of Public Health or in the Insurance Commission or in stuff like that. So the fact that we're bringing it up doesn't mean that we are going to take prime responsibility, but it's important, and I'm really glad for my fellow commissioners adding to the list that I began, and I'm sure David's taking good notes. We just don't want to, and the idea of nursing homes, the idea that Don Berwick talked about, and others about the fact that COVID has hit populations minority populations much more serious than others. The whole issue of social determinants become very important. But I don't want to stop this discussion. So anybody else want to jump in? Ron? Unmute yourself.
One of the things that I think we need to look at as it relates to the benchmark is the small community hospitals versus the large institutions. I think a lot of these small hospitals could really have problems going forward. And I think we need to take that into consideration when looking at the benchmark. I don't know if we can actually have a different benchmark or whether that even makes sense. And I think that's something we need to look at. And it also relates to the quality of care. If if these systems need to look at that bottom line, they're going to have to start cutting costs. And my other concern is, how does that impact quality? And I think we need to look at that. Thank you.
All right, good. Anybody else want to join in?
Yeah, I can offer a couple of thoughts. One on David's point about nursing homes. There were dramatic differences in the nursing homes. There were some that escaped COVID entirely, and there were some that were death traps. So it is a public health failure. I don't know where we have a role, but it would seem to me that we should at least be collecting data going forward, even if it's just census data. So we know what the total resident population is in senior congregate facilities, because we missed it. Everybody missed it, and we should have seen it coming. We should, but this is a public health department matter, understand the difference between inspections that with regard to infection control that were on task and measured correctly, and look at the failures and understand why those infection control procedures did not work. Again, I don't know where that's a commission capability, but it certainly falls under the big umbrella of healthcare quality and cost going forward. This is an industry that is it's not going to. I think the whole entire healthcare industry is not going to return to normal as we've known it, but the nursing home industry will lead the way to different models of care. So we have to somehow measure where people are going.
Well, this is a good area to indicate that we stand that the major responsibility for the nursing home industry really resides with the Department of Public Health and equally the Medicaid program, given the large percentage of the dollars that flow to the nursing homes coming from Medicaid. Lauren, you can tell the people in the, we'll stand ready to help in any way they would like. We will, we recognize that in that case, we have not played a central role. And we recognize that the responsibility is primarily with them, but if there's any help they would like, I would hope they would ask. Tim, do you want to jump in?
Can I finish up, Stuart? Just
Sure.
two quick points.
Oh, sure. I'm sorry, Chris.
Yeah, that's okay. One, another phenomena which is happening to some extent in Massachusetts. I'm aware of it happening a larger extent in other states, and that is the movement of acute care to the home setting. Better, quicker, cheaper, and in the case of avoidance of nosocomial infections, safer. So it is a real phenomena, and it is a enormous cost reducer as a substitute, of course, to acute care beds. I'm aware of one hospital in Massachusetts that does not want to reopen 40% of its beds. Feels like there are 53 DRGs that can lend themselves safely to home care, given telemetry and telemedicine, and these are technologies that have been there but have not been welcome because of, I believe, because of the overriding imperatives of fee-for-service and filling beds. And that leads to my last point that I think should be on our radar, and David Auerbach's slides introduced it. and that is the what's the right word? Willingness to consider or desire to participate in more capitated systems. So this is a moment in time where obviously those groups that operate in a prepaid practice did not face the economic calamity and had, in fact, additional motivation to manage their populations remotely so that they would not be, they wouldn't get sick and they wouldn't consume expensive resources. So knowing what the payers are thinking, doing, knowing what the big provider groups are thinking, doing with regard to movement to risk, I think is this is a time like we may never see again, with not just bending the curve, but the cost curve, but actually turning the cost curve negative potentially. So that gets to the benchmark and what we're going to do with that. So again, I don't know how we proceed. Maybe it's with asking the big provider systems and the payers to inform us what they see in terms of, not in terms of benefit design, but what they see in terms of change in reimbursement models.
Those are a number of issues. Let me get Tim and Barbara into and then maybe we'll come back. Well, let's come back to Chris. You've raised a number of issues. Tim?
Thank you. Head spinning with all of this, given the list that we have in front of us on the presentation and the additional items that have been listed, which I think all are critically important. Figuring out the HPC's role in all of it. I think the point was made by Stuart, by you, around what is our role in some of the things that Don laid out, which are critically important for the preparedness for the next round of this and what we need to be doing. One of my comments, I think it's still pertinent today at the committee meeting, was just really looking at all this through the equity lens, that we know different communities have been impacted by this. Both the caregivers are majority people of color, not in all titles, but many titles. They're the communities that get hit the most by the impact of the COVID-19 in terms of deaths, as well as the hospitals that they rely on and the place that they receive care are also in the most jeopardy financially based upon the outcome. So I think as we look at all this, is just to the points that Don made around structural racism and what we're doing about it. How do we put an equity lens on all of our research as it relates to the impacts? Because we know that not all providers are equal in the impacts and not all communities are the same. And so I just think it's a really kind of the frame, the conversation and the research going forward. I think it's really important to do that. And I think clearly on nursing homes, which keeps coming up, and I've raised a number of times at the HPC, just needing to better understand what is going on in this market. Undersecretary Peters has done a great job managing the response in a very difficult time. We've had a year-long commission to come up with some recommendations. But I think most important, how it fits in with this list of priorities is in the workforce capacity. I mean, we saw it in the slide before, the impact of jobs in nursing homes. People are scared to work in nursing homes. They're concerned they're not going to get the proper protective equipment to work there, and they're going to get paid a little bit above minimum wage. We've done a little bit better with the increased Medicaid rates now, based upon meeting standards to increase rates of pay, but we know we're going to have a significant challenge when we go back to it. So I think it could fit within the workforce capacity piece of the research here. And I think it's really important that we get an understanding of what that model is going to look like in the future. We know, talk about volume being down in hospitals. I think if you look at the capacity in nursing homes, it's even lower than it's ever been because people are pulling people out or fearful to put people in. And that's going to cause other problems within the overall healthcare delivery market. So just really think we should think about this as an equity lens and what the important, particularly around nursing homes, the impact around the workforce issues. And then finally, and it just seems that's one big area, and I think Dr. Kreider talked about it earlier in terms of employment impact on payers, but when we talk about differential impacts within this time period and what it means for us going forward, I think we got to take a look at the payer side as well. That if there's a decrease in 10% of spending, what does that mean for the administrative costs or the profits by insurance companies and payers during this time period? And what role could they play and be helpful in helping to solve the other issues within the market in terms of community and safety net hospitals and the impact they're going to be having based upon the drop in volume. So I just think that's one big area that I don't see listed here is how are we looking at the payers and their impact or not their any
Very good.
time period.
Very good. Yes, thank you, Tim. All right, I have Barbara and Cassandra and Marty on my list. Barbara?
Hey, thank you, Stuart. I want to support the concepts about looking at the data from nursing homes because of the large percentage of people who both became ill and who died as residents or providers in nursing homes. But I think we also have another opportunity, which is as we look at the data that shows us the incidence of illness and shows us the incidence of death, that there's opportunities in all of those data points to recognize where our strengths are and in this case, where our weaknesses are. So as we look at the model for looking at nursing homes, can we also think about a model that allows us to look at things such as prisons, such as confined communities? I'm thinking about shelters and the way in which shelters are packed, especially in the wintertime. I'm thinking about our prisons. I'm thinking about assisted living communities, any community that is confined, if you will. We also, I think, need to take a look at communities. We know for a fact that the minority community, the communities of color, have been extremely heavily hit by this virus. What data is important to understand from that? Our goal, I think, at least part of our goal, and I think the entire state's goal, is to make sure that the lessons that we learn from this don't have to be learned again, that we get markedly better at providing care and providing services during surges. A surge, it can be a pandemic, it can be any kind of crisis that puts an immediate, sharp, and very strenuous stress on our environment, on our healthcare environment, and on the community. Learning from that, I think, is critical. And then the last comment I want to make is I want to come back a little bit to some of the data that David Auerbach was showing us in terms of telemedicine and telehealth. And I want to caution a little bit that as we learn from this experience of what we know about telehealth and what we can do from telehealth and with telehealth as a result of learning from COVID, that we don't move too quickly to break up the infrastructure that supports the one-on-one personal engagement with providers. I think we run the risk of becoming a transactional process if we do that. And I think healthcare is too humanistic and requires too much of a human connection to be done well and to be done minus that. So just a caution about that. And thank you, Stuart.
No, that's very helpful. Cassandra?
Yes, thank you. I would agree with everything that's been said. And I just wanted to quickly add that I would encourage the HPC not to lose sight of the good work that it was doing before the COVID-19 crisis hit. And in particular, I'm thinking about the research that had been performed on PBMs and also the drug pricing review work that was just kind of beginning to get underway. Those are great tools and I think can still inform policy choices and financing decisions that the state makes moving forward. And I would hope that that work can be kind of continued on and applied to this new world that we find ourselves in and leveraged moving forward as well.
Thank you. Marty, I know you had some comments.
Yeah, so I'll try to be quick. I agree with all of the recommendations that have been made. I would just like to say around the health equity and the impact that COVID-19 has had on people of color, we should also look carefully at the undocumented population here, because these are folks who really don't have access to care, have been hard hit by the virus, and a lot of folks who are unwilling to get care for fear of some of the immigration rules. I would also say that we have yet to see the real impact of this on behavioral health. I think we're going to see a surge in requests for behavioral health assistance, both from mental health and substance abuse. Understanding what those impacts are is going forward is going to be important. And the last thing I would say is that I think if one thing that I've noticed from the COVID-19 is that, you know, it underscores that we have a fragmented system of healthcare, nursing homes, behavioral health, primary care, institutional care. And I guess maybe this is a lead-in for the second half of the discussion about the MassUP proposals, but it really does underscore that we need to look at these systems and try to get away from these silos and really try to integrate care in a better way. Thank God we had a command center, but that command center isn't around for most, post-crisis. So we need to think about how these systems work together in a more coherent way. Thanks, Stuart.
All right, well, that's a good lead in to Lauren and all the things she's doing. And, we're sort of out of time this time, but this was really a great discussion. And we're going to make sure that we have ample opportunity at future meetings to continue it. But Lauren, would you like to get the last word in?
Oh, sure. I actually just wanted to respond to sort of Commissioner Blakeney's comment about how do we take the lessons learned so that we can better prepare for the future. And I will say that, across the various work streams of the command center, we are in the process of developing what we're sort of calling playbooks, because we know that there is likely a second wave coming, and we want to do exactly what has been recommended here is taking lessons learned, taking some of the data that we've collected, specifically on nursing homes. We are collecting a lot of really sort of rich data from the nursing homes as a result of this, and trying to parse apart, look at and understand the trends that we're seeing, because we're seeing a lot of historically high quality facilities, for example, with really high infection rates, really high mortality rates, and trying to understand where are their correlations. And so taking all of that, doing the analysis, and we hope to use that to, again, inform future strategies and create these playbooks so that we are ready and prepared at the next point that we have a wave.
Well, before I go any further, I do want a big shout out to the governor's task force, which I know, Lauren, you're a part of, and David and our backup people and our fellow commissioners, the Secretary Mary Lou Setters. It's just for someone who splits their time between Massachusetts and North Carolina. We have a very good system here too, but I would take what's going on in Massachusetts as second to none. So kudos to you. And as Marty pointed out, it's hard to maintain that level forever. So we will need institutional structure to solidify some of the good things that have been done by the task force, but kudos to the group. Okay, well, unless there's someone that wants to jump in, again, I want to thank all of you for really insightful comments. Clearly, we've established an agenda, which will take an awful lot of work, particularly among our staff. But these are both complicated and bad times, but there are also times for really exciting activities, as Chris pointed out, to make our system more equitable, lower costs, and higher quality. So with that, I'm going to turn the program back to David Sells.
Thank you, Stuart. And just to put a little bit of a bow on this conversation, first of all, thank you all commissioners for that really great conversation. And what we will plan to do is to really kind of put together a summary of this conversation and build out a work plan that will include across a couple of the different priorities, what exactly our proposed role would be, some potential timelines for action steps, and really begin to build out a work plan, as I said, for the year. We understand that this needs to happen quickly and rapidly, and so I would commit to working with you commissioners, even in between meetings as appropriate, to work on that plan, so that we're moving at a rapid pace to meet the rapid change that is happening around us. So expect to hear from us, and I hope to be able to call on all of you to continue to assist as we focus and prioritize our agenda for the year. And to Cassandra and Lauren's points, a lot of this work we're talking about today and on the slide is in addition to our other programs and mandates when it comes to drug pricing review, review of material change notices, certifying accountable care organizations. So all of that great work continues. So we'll plan to hear back from us soon. So the next agenda item is on the benchmark. So it is strange to think that 3 months ago, many of us were together in a room at 50 Milk Street for the hearing on the modification of the 2021 benchmark. For me, that was the last time I was in the 50 Milk Street offices with HPC staff and with many of you, and that was 3 short months ago. A lot has changed in the world, obviously, and yet we still have this incredibly important responsibility to set the benchmark for transparent measurement and accountability. So before I walk through kind of the legal process and review some of the testimony that we received, just want to reiterate a few facts about what the benchmark is and is not. The benchmark is really a long-term strategy. It is not an annual cap on spending, and there have been years where we have exceeded the benchmark, and there have been years where we've been below the benchmark. On whole and on average, Massachusetts has controlled spending below that target over the past 6 years. I also want to just re-emphasize that one of the main accountability tools to the benchmark, or the main accountability tool to the benchmark, is the potential for a performance improvement plan. And the Health Policy Commission is required by law to consider whether the factors that led to the increased costs of a healthcare entity can be reasonably considered to be unanticipated or outside of the control of that entity. So I think it is fair to say that when it comes time for the HPC to review entities for their spending in this time period, the current reality will need to be weighed heavily as an exogenous factor impacting spending. And of course, the HPC may elect not to require a performance improvement plan in any given year. So this slide just walks through our annual process. As I mentioned at the last committee meetings, the timeline for this process will change in the future, but we are here today to finalize and set the benchmark for next calendar year. So again, to be clear, this is growth between calendar year 2020 and calendar year 2021. By law, our authority to modify the benchmark is limited. It is prescribed by law that in the mid 6 through 10 years of the Health Policy Commission that we can, the benchmark will be set at the default rate of potential gross state product minus a 0.5 percentage point, or 3.1% in this case. The HPC can elect by vote to modify that benchmark up to any number between 3.1 and 3.6 if there is a modification that is subject to legislative review and additional processing. Beginning for the benchmark for 2023, the Health Policy Commission will have a much broader authority to set the benchmark at any amount, but that then too will be subject to a process of review. So we are still in this middle period of having some limited authority to modify between 3.1 and 3.6, again with the default rate in law of 3.1%. So how we go about considering whether a modification is warranted, a big part of this process is the public hearing, which we held in March, along with members of the Joint Committee on Healthcare Financing. And if the board elects to modify the benchmark, this is detailed in the 5th bullet here under the blue flag. We vote to modify the benchmark, we must submit notice of that intent to the Joint Committee, and there could be potential further review by the Joint Committee of such a decision. In past years, the board has elected to not modify and to remain at the default rate of 3.1%, the lowest growth rate allowed by law. So this is just a process timeline. I will move through this quickly. We did receive testimony from a number of organizations, both in person and in writing. At the time, this was at the beginning of March, most organizations testified in support of the 3.1% benchmark, while there were certain factors that different organizations raised as key drivers of spending to watch. I think obviously these takeaways and this testimony was largely submitted before the impact of COVID-19. And here too, then we have a summary of the testimony that we received from all of the different organizations and whether they indicated a position about where the benchmark should be set. Again, I want to caveat that many of these were submitted prior to COVID-19. So the question to the board today is on setting the benchmark for this motion should read calendar year 2021. Apologies, we'll note that during the vote. And I will turn it back to you, Stuart, to lead any conversation or discussion.
Okay, so I'd like to put on the table that we continue the 3.1, but then open it up for any comments or questions. We are required to take a roll call vote. So, but first let me open it up for any comments by any of the commissioners. If I don't hear a tick, 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 if I don't hear any, then we will go to a roll call vote, but let me give another minute. Colleen, I don't see anybody want to jump in, they can. If not, we will take a roll call vote to maintain the benchmark.
I'll jump in. Stuart, I was on mute. Sorry about that.
Okay. Sure.
What are the implications, do you think, or does anyone think, if we, when we are meeting in, let's say, October, and by the way, the cost trend hearings, maybe that's something we should also put on the agenda, given the magnitude of COVID and the impact. This year's cost trend hearings could be better than ever. So thinking about that agenda and who participates, but that was a loose association. I was saying, what are the implications if in October we're sitting on the -10, that expectation that we saw in the slides 45 minutes ago. Does it make our do we have a chance to revisit our 2021 number? In many ways, it seems because of the unique moment in time that it, while by custom, I don't think statutorily, but by custom, the commission establishes a first shot at it in June. Do we make an exception in this year and say, let's wait and see how things play out before we throw a number up there?
So let me just say, without necessarily completely answering that, legally, I think we're required, as David Seltz pointed out, we're really limited to 3.1. But let me make a more general statement, is that the whole benchmark really, remember, is a long-term. We tend to think of it in the narrow sense of the year in which we're focused, but the reality is that it's really a long-term number. And it wouldn't surprise me for a while this year, we may be in that -10, a number that you mentioned. But it's quite possible that things will bounce back faster and more expensively than we expect, and that next year we may be higher. And ultimately, as we have pointed out in the past, we really need to look at the long-term trend. I don't know. As I said, you can, just for sake of an argument, you can still subject me to be a skeptic that the health system will accept permanently lower spending of the -10 variety. But if it does, I think we will push hard when we gain greater authority to make the benchmark much lower. But David Seltz, I don't think in the short run we have much flexibility. But maybe I'm wrong.
I think from a legal matter, we have are required to set this benchmark by April 15th. So on a kind of a clearly legal, practical matter, we are why we have added it to this agenda today. I think the board may have a robust conversation about how we interpret and apply the benchmark in this time period. And while the 3.1 may kind of sit there on the books, how we apply it, how we examine it, how we maybe write our cost trends reports, how we frame our cost trends hearings, I think can be subject to some of the nuance that Chris Kreider and others are raising, and that will be necessary to raise, to be cognizant of a reality that predicting growth from 2020 to 2021 is exceedingly difficult. And I would say the benchmark is not necessarily a prediction tool, and more about a long-term signaling that affordability matters, and that we are trying to restrain over time the growth in unnecessary, healthcare spending, and to be able to have a tool to examine that and a bench and a target by which to measure against. My 2 cents, but I know David Cutler also raised his hand. So
one of the areas we have not talked about is Medicare. Now, it's my understanding that during this epidemic, the Medicare payment rates to hospitals have been given a boost of 20%. Now, there'll be pressure to eliminate that, but knowing the healthcare industry, there's going to be pressure to maintain it. And one of the reasons why we have been able to come in under the benchmark is because of much lower spending on the part of Medicare over the last 4 or 5 years, to the point where hospitals claim they're losing 11, 12, 13, 15% on Medicare. Of course, that's in the eye of the beholder and what the costs really are. But nevertheless, we haven't talked about Medicare. So as David's pointed out, I think we should talk about this as we move along. But it's still unclear what the future number is going to look like. But with that said, Ron, you wanted to say something. Ron, unmute yourself. Ron,
Yes,
did you
I'm
want to say
unmuted,
something?
I think.
Okay. Did you want to say something? Well, will you figure it out? David Cutler?
Yeah, Stuart, I want to second your suggestion that we continue with the target at 3.1%. So there are a couple of reasons for this. One is that, as you said, and as David Selt said, this is a long-term target, and it's not something that's supposed to be variable by year that much, other than when we think the fundamentals of the economy are changing, which hopefully they're not changing very much. In terms of will we miss the target? You know, my sense is we'll come in way below the target this year in all likelihood, because we're likely to be down by a lot. We may then, there may be some catch up early next year or sometime next year as people return to doctors' offices, particularly if there's again a COVID impact in the fall, as Lauren was suggesting. In that case, as we evaluate next year, I think we would think of it a little bit like what happened when the hepatitis C drugs came out, which is there was an event that led to more utilization of medical care that in the short run increased cost. In that case, it was because the hospitalizations prevented were down the road, whereas you took the medications up front. And we said, okay, fine, but we want to see evidence that outside of that, the growth in medical spending was not unusual. And I think we would be able to do the same thing here. That is, if cost growth is very high next year, we could come back and say, okay, fine, let's figure out how much of that was catch up of folks who didn't have services because of COVID-19. And we want to see how the rest of it is doing. So I think we have the procedures in place to adjust to these temporary things. And the fundamentals, I don't think, have changed.
Ron, did you get did you want to jump in? Is your system working? Well, if it does, let me know. David, okay, why don't, Colleen, you want to take the roll call?
Yes, I need a motion.
Okay, well, I'll put it on the table, the motion. Is there a second?
Second.
Okay.
Second from Rick Lord and Don Berwick. Thank you both very much. Okay, I will start calling roll. Commissioner Altman.
Aye.
Commissioner Cohen.
Aye.
Commissioner Cutler.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Master-Giovanni. Aye. Commissioner Berwick.
Aye.
Commissioner Kreider.
No.
No. Commissioner Foley.
Yes.
Commissioner Lord.
Yes.
Commissioner Peters.
Yes.
Commissioner Roeder.
Aye.
Aye. 10-1. Back to you, Chairman Ullman.
All right. Well, I'm going to turn it back to David for the remaining issues that we need to get in this session.
Great, thank you, Stuart. So recognizing the time and that we do have another important agenda item and a vote today, I hope that some commissioners will be able to extend perhaps a little bit beyond 2 p.m. So that we can take a vote on this important topic. So I had a very long introductory remarks to this really incredibly important agenda item that we're so thrilled to be able to present to you today and to move forward. I will do the brief version of that, which is first to just say a thank you to Secretary Sutters and Undersecretary Peters for their support of this initiative over many years in developing this concept of MassUP, which is a really unique initiative that spans multiple state agencies working together on some of the biggest challenges in our society and in healthcare. I also want to thank Commissioner Burrell and the wonderful staff at the Department of Public Health who've been with us every step of the way in building this program. To our own team at the HPC, who've put in probably thousands of hours developing a program, soliciting applications, reviewing all of the applications to get to this point today. Thank you. And I think most importantly, thank you to the applicants and to many of the community partners who came together with incredibly thoughtful proposals around how they can work together across many different organizations, but with a common goal of improving health in their communities and reducing inequities. This program, I think, it's been a long journey to get to this stage today, and I do feel a sense of serendipity that we were able to launch this effort now, especially on the heels of COVID-19 and with recent events highlighting the need to address systemic racial inequity. And this program is really made for this moment, even if we didn't know how great the need was going to be. So I'm going to turn it now over to Kelly Hall. And Kelly, I would recommend not necessarily having to recap the program, but really getting to our 4 recommended awardees.
All right, thank you, David. I'm happy to do that. As I said, I think David's provided a nice orientation to MassUP, and I think several of you have heard about it.
Can you come closer to the mic, please?
Of course. Sorry, I don't have a voice for radio like David. Is that better?
A little.
Okay. Better still? Okay, this is about as close as I can
get.
Much
better, thank you.
Okay, no problem. All right, so let's skip ahead past the introduction. And I just want to quickly orient folks to what we were looking for. So back in December 2019, the HPC issued a request for proposals for moving Massachusetts upstream. We anticipated 3 to 4 awards of up to $650,000 each for a 3-year program that would include technical assistance and evaluation provided by the Department of Public Health. To David's point, it was critical that the provider organizations that applied bring at least one community-based organization to the table. They had to propose a particular social determinant of health that is leading to poor outcomes in their communities. And finally, they had to offer a governance structure that created equity and accountability among all the partners. I do want to note, though it's not on this slide, that another key theme that appeared in the RFP and in all of the responses was asking the awardees to speak for the applicants, sorry about that, to speak specifically to how they were going to integrate principles of racial equity into their proposals and how they were going to ensure authentic community engagement. Next, please. So I'm pleased to report that we have 4 recommendations: Cooley Dickinson Healthcare, Haywood Hospital, Massachusetts General Hospital, and Mercy Medical Center. And I'm going to dig a little bit into each one of those, but I just do want to pause for 1 second and make a couple of observations that I think are relevant to all these proposals. The first is that the provider organizations who were recommended for awards, and in fact, all 22 provider organizations that chose to apply, understand clearly that as caregivers, as major employers, as sources of community benefit investment, and as respected organizations in their communities, that they have both a unique responsibility and opportunity to lead, as well as an economic motivation to make investments that will get at the upstream causes of poor health outcomes and disparities that they receive reflected downstream in their patient populations every day. Secondly, that at the same time, they very clearly recognize that they can't do it alone. In each of the proposals we saw very clearly that they valued and recognized the necessity of engaging with the community, supporting the expertise and the infrastructure and the lived experience that was already there. So while the named awardees are all healthcare organizations, I want to be very clear that the award recommendations also speak to the strength of the community partnerships in these proposals. So let me dig in with a little bit of detail for each one. Okay, starting with Cooley Dickinson Healthcare. So Cooley Dickinson, in collaboration with the Collaborative for Educational Services, Hilltown Community Health Center, and Hilltown Community Development Corporation, proposed an initiative specifically to address food systems and security in Hampshire County. Among their top priorities is the development of the Hampshire County Food Policy Council, which has a goal of strategically aligning a number of organizations already working to improve regional food security and address systemic barriers to accessing healthy food. The activities of this partnership will be informed by a 2017 Food Action Access Plan and includes activities such as collective action for policy change in food policy, developing farmers markets and resident governed community gardens in foods insecure communities, and organizing residents in affordable housing complexes to connect them to food access interventions. Next, please. Haywood Hospital, in collaboration with the Community Health Network for North Central Mass, GFA Federal Credit Union, Growing Places, the Winchendon School, Three Pyramids, the Town of Winchendon, and Winchendon Community Action proposed the formation of Heal Winchendon Economic Empowerment, with the goal of improving health and well-being by building social, financial, and community assets that lead to community empowerment. The activities these partners will undertake include resident leadership and civic engagement, updating the Winchendon Master Plan specifically to promote economic mobility, providing personal financial education, and assisting residents in building credit. They also have a policy workstream focused specifically on mixed-use developments. Next, please. Massachusetts General Hospital, in collaboration with the neighborhood developers, Connect, the Chelsea Collaborative, the City of Revere, the City of Chelsea, and MassHire Metro North Workforce hope to establish a cross-city coalition specifically to coordinate municipal workforce development efforts and increase access to skilled, benefited jobs for residents of those communities. As part of this effort, the partnership will review and align workforce development plans across Chelsea and Revere. They'll align job training programs to identify growth sectors in those communities, advocate for municipal policies that support economic opportunity for community residents, and bolster programs that provide technical assistance and promote access to capital for women and minority-owned businesses. And last, but certainly not least, is Mercy Medical Center. So Mercy Medical Center, in collaboration with the Springfield Food Policy Council, Open Pantry Community Services, Fertile Ground, Gardening the Community, and Square One, will address food systems and security in the North End, South End, and Mason Square neighborhoods of Springfield. Through this investment, they will establish a Springfield MassUP Food Justice Steering Committee that will work to build a more equitable and effective food system that will support residents in living healthier lives. Among the activities that the partnership will undertake as part of this program are advocacy to address the SNAP and HIP gaps and other relevant food policy issues, modifying public transportation routes to enable food access for seniors, engagement with food retailers and residents to create a food retail committees to expand the number of locations at which community members can get access to affordable, healthy food. And integrated into all of those activities are broad efforts to offer resident leadership development activities. Next slide, please. So if the board approves these awards, we will move expeditiously to begin contracting through the summer with the goal of launching the program in earnest in September. So that is about as quick as I can go, but let me pause and ask if there are any questions or comments from the commissioners.
I want to thank you, Kelly, for taking us through. I know how hard you've worked for doing this, but this is an important program, and there is now before you the motion to accept the recommendations of the staff to fund these 4 important projects. Is there a second to the motion?
Second.
Second.
Okay.
Okay, any comments of anybody? Anybody want to raise any questions of the commissioner?
Stuart, it's Barbara.
Barbara, please.
Yes, thank you. As chair of the committee under which this work is done, I just want to say I'm absolutely thrilled with the quality of the proposals that we saw, all of them, not just the ones that were improved. I know the staff and the review team struggled mightily with the number of excellent proposals. And I hope going forward that not only are these programs highly successful, but that we continue to find a way to support those programs who are equally as exciting, but we just didn't have the funding to support. So I'm thrilled with this, and I can't wait for us to get started.
Very good. Any other comments?
Stuart, if I could just add, when this was presented to the committee, I was very excited about it. I really think it's the right piece of work for the right time. I also have to commend the hospital industry. I was a little skeptical that we wouldn't get a lot of proposals from hospital systems, and I was proven wrong. So kudos to them for stepping up.
Very good. Any other comments anybody would like to make?
Yeah, I just have a quick question if I could.
Who's that?
Tim?
Go ahead, Tim.
Thank you.
Yeah.
Great work by the committee, and the proposals look great. So please don't take my question or comment to be reflective of the work. I guess, what consideration do we take into, what factors do we take into consideration around the grantee being able to provide this program without support from the Health Policy Commission? I think there are a few hospitals, one in particular, that comes to mind that has resource to probably fund this without needing additional support from the state. I'm wondering how we took into consideration the ability for one institution that would not be able to do it without funding versus another institution that probably could find the funding to do it without relying on a grant.
I think, oh, go ahead, David.
Nope.
No, go.
I was going to turn over to you.
It's a fair question. I would say, the first consideration, frankly, was the quality of the proposal. Then the second thing, we obviously looked at budget efficiency. I would also say one of the considerations that we looked at as we evaluated the proposals was the percentage of the dollars that were going to the community-based organizations as opposed to covering activities within the healthcare delivery organization. And we tended to give weight to those where more dollars flowed through for some of the, I think because some of the considerations that you raise. But David, you look like you wanted to add to that.
I was just going to reflect that in some cases, the applicants are also putting some in-kind resources.
Yes, absolutely.
Okay, any other comments or questions? If not, we will have a roll call vote. Colleen?
Great. I'll start with you, Chairman Altman,
All right, aye.
Commissioner Cohen,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Cutler,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Berwick,
Aye.
Commissioner Kreider,
Aye.
Commissioner Lord,
Aye.
Commissioner Peters,
Aye.
and Commissioner Roeder.
Aye.
Unanimous vote, Mr. Chairman?
All right, very good.
I took a comment by
And,
comment, and I get a vote, right? Aye.
And we will get progress reports, Kelly, from time to time. So thank you for a job well done. Very well done. David, I'm going to turn it back to you.
All right. Thank you, commissioners, and thank you, Tim, for your support. The remainder of the presentation is program updates and other workstream updates that commissioners can feel free to review on their own time, and the public as well. So I think we're in a position to adjourn today's meeting, and look forward to engaging with all the commissioners in the weeks to come. We also have, I will note, an advisory council meeting that will be is scheduled for Wednesday, June 24th. So I'll look forward to that for all of those who are joining us on the YouTube channel as well.
Very good. All right. Do I have any final comments from any of the commissioners? Anybody want to give us a last word?
Come up, raise your hand.
Working thanks to the staff, Stuart.
If not, I would welcome a motion to adjourn.
So moved.
All right,
So moved.
second. All right, all in favor? Aye.
Hand up.
All right.
Aye.
Thank you all. This was a very informative meeting, and I'm sure our great crack staff will be hard at work to develop a lot more information. So all take care and stay safe.
Thank you.
Take care.
Thank
All
you.
right.
Everybody, bye-bye.
Bye now.
Thank you.